And the first thing I thought was, well, if the club is families affected by children with rheumatologic disorders, it's not a club that anyone would really want to join. And why are we even calling it a club? And then I thought about it a little more, and I was thinking that, well, actually, there's more to it than that. Because you people here, everyone here, it's not just families affected by children with rheumatologic disorders or rheumatologic disorders in the family. It's families who choose to do something about it. Families who choose to learn as much as they can, to go out of their way, travel the distance, do everything they can to make sure that their child, whatever rheumatologic disorder they have, has as normal of a childhood as possible. And that is a pretty great club, because no one wants their child to have a rheumatologic disorder. But to be dedicated and to want to really do everything you can to help your child be as quote-unquote normal as possible, I think, okay guys, welcome to the club. So this is a little bit of a difficult talk to give because there are so many rheumatologic disorders, and different people here probably are affected by different ones. So I'm not going to spend a lot of time on any one disease. I'm going to talk more about things that affect the children in general. But I will just do like 1 or 2 slides on the more common ones. I apologize in advance if I don't mention whatever your child has. I will take a lot of questions at the end, but it's going to be relatively general. So regardless of what your child has been diagnosed with, parents' first reaction tends to be what? My child's too young for arthritis or lupus or vasculitis. And then once they go home, it's not what anymore, it's why. Why is this happening? Is it something we did? Is it genetic? Is it environment? Is it something we could have prevented? And the bottom line is no one knows. And that's one of the biggest problems with autoimmune disorders. We have no idea what causes them, what sets them off. We do think that there's a genetic predisposition. Autoimmune diseases in general tend to run in families. Some family might have multiple sclerosis or Crohn's disease or some other autoimmune disorder. But then there are lots of families where no one has any autoimmune disease. And even when they do identical twin studies, exact same genes, most of the time there's less than 50% concordance rate, meaning if one identical twin has it, less than half the time the other one has it. But sometimes it's close to 50%, whereas in just siblings, it's usually 2 or 3%, or maybe in lupus it's 30%. So genes definitely have a lot to do with it, but by no means the whole story. And a lot of research is going on now looking at different genetic backgrounds and trying to figure out what predisposes people to these illnesses. And then, if you have certain predispositions, what in the environment may set it off. How do I make that go away? There is no cancel. Cancel? No? Okay, I'll ignore it for now. What? Okay, so again, a lot of people think that different viruses may set it off. A lot of people start having symptoms after they were sick with something else. Anything that gets your immune system going. Some people think vaccinations may set it off. Some people think that physical stress, maybe something you breathe in the air. But again, the bottom line, unfortunately, is that nobody knows. Another difficult part with rheumatologic disorders is the diagnosis. Most children are not diagnosed whatever it is that they have right away. Very often, they feel achy, they may have swollen joints, and you ask, well, did they hurt themselves? And there's almost always some history of maybe some mild trauma. Well, he was playing soccer, or well, she was doing gymnastics, and maybe that's how she hurt her knee. Go to the orthopedist, and the orthopedist says, well, nothing's broken, maybe we should immobilize it for a while, maybe we shouldn't, maybe we have some blood tests, well, they don't really show anything. So very often, there's a really long lag between the first symptoms and getting the diagnosis, and sometimes it's because it's a diagnosis of exclusion. For example, a lot of viruses can give you symptoms that are just like juvenile arthritis or lupus or even dermatomyositis. And then the viral illnesses kind of go away on their own, and the rheumatologic ones don't. So sometimes you actually need that time to make a diagnosis. If you look in a textbook to define juvenile idiopathic arthritis, you have to have the symptoms for at least 6 weeks, because there's so many viruses that look just like that but go away after 2 or 3 weeks. So sometimes that's kind of the nature of the beast. You have to watch it over time. And sometimes it's because there are so many physicians in the community that just don't see a lot of rheumatologic disorders that they don't necessarily recognize it right away when they do see it. And that's part of the mission of the Arthritis Foundation, is to make everyone more aware that yes, children get arthritis too. And yes, if you see this, get them to a pediatric rheumatologist if possible, and there are none, adult rheumatologists, as soon as possible. But this makes it very frustrating, both for the child and the family, because no one knows what's wrong with them. A lot of frustration also comes from the unpredictable nature of these illnesses. I always tell families that it's a little bit like being on a roller coaster. You go up, you go down, go up, you go down. With the right medications, you kind of level the playing field a little bit, but still, there are days you have bad days. Sometimes it's the weather, it's going to rain out, and someone who's doing great, all of a sudden they can't get up that morning, or they're really stiff. Sometimes it's like they get a little virus, and they were in remission for a year, and all of a sudden the symptoms start acting up again. Sometimes we have no clue what's set up. The child's doing absolutely everything right, taking the medications regularly, nothing happens, and all of a sudden the medicines that are working so well don't seem to be working well anymore. And we don't really know what causes that. But for all these rheumatologic disorders, the most common cause of a flare is not taking the medications as prescribed. And I'll go into that a little bit more later. But sometimes that's the reason, and sometimes we have no idea what the reason is. It just kind of goes that way. And unfortunately, you and your child just have to know that just because today's a bad day doesn't mean tomorrow won't be a great day. It goes up and down, and we kind of deal with it as it comes, and it will get better. The other thing, again, I'm going through all these frustrations because this can be a really frustrating time, is that the prognosis. Say, okay, well, what's going to happen to my child in 10 years? And most physicians will tell you, I don't know, because there are so many possibilities. All these rheumatologic disorders, they can have very, very mild courses, they can have very severe courses, and they can have pretty much everything in between. Now, luckily, with the medications we have now, most children do so much better than they did years and years ago, especially for juvenile arthritis with JIA. When I was a fellow and we didn't have any of these biologic medications, I had a lot of patients who were severely debilitated by their arthritis. Now, it's pretty rare. Some people still have arthritis that's not responsive to most of the medications, but it's really rare. There's so many new medications on the market now that most people do very well. So it's encouraging. And it's very encouraging that they're doing all this research to try to find more and more medications and to find the cure. So it's an exciting time to be in my shoes in rheumatology, because for so many years we couldn't do all that much. And now we can really do a whole lot. But again, for any individual patient, there's no way of saying, this is going to go away and outgrow it, this person will never outgrow it, she won't outgrow it, she's going to be fine, he's going to have a limb, you just never know what's going to happen. And then just some prevalences. JIA, and I use that, as my example, is so much more common than most people think. It's more common than childhood diabetes. It's more common than cystic fibrosis. So how come every time you walk out and you say, my child has arthritis, or the child tells the teacher or gym teacher have arthritis, everyone looks at him or her and says, you're too young to have arthritis. I mean, I don't know why we do such a poor job of publicizing this. And it happens to me all the time. I tell people I'm a pediatric rheumatologist. But what do you treat? Well, kids with arthritis and lupus. Kids don't get arthritis. So I sit in my office and control my thumbs all day. But it's so hard to get the word out there that all these rheumatologic disorders affect people from under a year old to 99 years old. It can be any age at all. And I think that's also one of the missions of the Arthritis Foundation, is to spread the words that kids get arthritis too, so that children don't have to go through that you're too young to have arthritis, or you're faking it, or no, you don't. It's bad enough to have something, but then have people not believe them. That's even worse. So, we have to spread the word that this does exist at all ages. For almost all rheumatologic disorders, the cause is some type of inflammation, an autoimmune, autoinflammatory disorder. Now, inflammation can occur in any part of your body, and you can have symptoms in any part of your body. In juvenile arthritis, the most common thing is inflammation in the synovium, which is the tissue that lines the joints. So that synovium, that joint tissue, is very, very thick. It secretes more fluid, and you have a swollen joint. If it happens in one joint, if it happens in all of your joints, you never know. And over time, that inflammation can cause damage to the joint. So that's what we try to do. We try to decrease the inflammation, not just so it doesn't hurt anymore, but that so down the road, there's no long-term damage. Because even, sometimes it doesn't hurt that much. The child, maybe a little stiff in the morning, but then running around, no, it doesn't hurt, I don't want to take the medicines. But it's not just for the pain, it's to prevent long-term disability. So that's why we want to treat all the inflammation. You can have inflammation in the muscles, which we call myositis, and that's really common in things like dermatomyositis. You can have that with lupus, you can have that along with arthritis. You can have inflammation in the blood vessels, which is a vasculitis. You can have inflammation around the heart or the lungs, and it's a serositis. So depending on what the underlying disorder is, you have inflammation in different areas, and wherever that area is, we basically use the same type of medications to get rid of the inflammation, because it's all more or less caused by the same process. Most children with rheumatologic disorders have to see an eye doctor regularly. JIA is the most common because they can get uveitis, or some people call it iridocyclitis, but it's basically inflammation in what we call the anterior chamber of the eye, and right in front of the lens. And again, this is something that over time can cause damage if not treated. So we need to treat that with medication, even if there are no symptoms, which usually there aren't. And that's why we say you have to have frequent eye exams, because the vast majority of the time, the child will not notice any symptoms whatsoever until it's really far along and they start having visual damage or loss of vision, and then it's kind of in a boat. You can stop progression of the problem, but you can't go back and necessarily fix it so well. So all children need to have their eyes examined regularly. Lupus can affect your eyes, vasculitis, Behçet's, medications can affect the eyes. Steroids can affect the eyes, plaquenil can affect the eyes. So almost anyone with a rheumatologic disorder needs to go at least every 6 months. But children with oligo-JIA, especially if they have a positive ANA, or even young children with polyarticular JIA, if they have a positive ANA, we actually recommend it for 3 months. So get to know your eye doctor pretty well. So now I'm just going to really quickly kind of run through some of the more common rheumatologic disorders, just so you kind of know all the different things we're dealing with. But like I said, because there's so many different ones, we can't spend a whole lot of time on any individual one. Probably the most common is juvenile idiopathic arthritis. And by definition, the J in the juvenile means it starts at under 16 years But if you're 16, 17, in the mind of a pediatric rheumatologist, you're still juvenile arthritis. But by the textbooks, it's supposed to be under 16, very arbitrary number. I'm not sure why that's what it is. And like I mentioned before, it needs to be at least 6 weeks because there's so many other things that can give you what looks like JIA, but it goes away on its own. And we classify what type of JIA based on the symptoms over the first 6 months. And the different types, we see oligo. Oligo just means few, so it affects less than 5 joints. We call it oligoarthritis. And poly means many, so 5 or more, we call it polyarticular. Then there's something we call ERA, which is enthesitis-related arthropathy. This spelled me. You know that spondyloarthropathy is what we used to call it. And this is the type of arthritis that mainly affects adolescent teenage boys. It's spondyloarthritis because it tends to affect the sacroiliac joints, which are kind of these joints right from your lower back. But sometimes that's later on. It can start with a hip or a knee, usually the big joints. And enthesitis, which is what you see in this type of arthritis, and you can see it with any of the rheumatologic disorders. The enthesitis is where the tendon inserts into the bone. So right where that tendon inserts into the bone, it can get very inflamed and can be very painful. Sometimes it's in the bottom of your feet, like a plantar fasciitis. Sometimes it's by the knee, and a lot of kids are first diagnosed with Osgood-Schlatters disease, which is common, but it's inflammation right where the knee tendon, the patella tendon inserts into the bone. So a lot of these children, because they don't have as much obvious arthritis or this inflammation where the tendon inserts, sometimes they're misdiagnosed for a long time also because it's this thing, and it's this thing, and it doesn't really get better, and things like that. Psoriatic arthritis, a lot of patients with psoriasis can have arthritis also. And systemic onset is the kind of arthritis that you have fevers, very often high fevers, 104, 105, with a rash. You have inflammation, it could be around the heart, it could be around the lungs, you can have a big liver, you can have a big spleen. And again, I'm telling you all these types of arthritis, but if you know your child has one type, it would be very odd to switch to another type. So if you're thinking my child has oligoarticular and I'm talking about fevers, well, your child's probably not going to go get those fevers. And if you have systemic onset and I talk about lupus, it's probably not going to switch over. I'm just giving you a little bit of an overview. Now, lupus, again, is often very difficult to diagnose because it can affect any part of your body. You basically make autoantibodies that, your antibodies that are supposed to go protect you and kill all the stress and virus and all these infections, for some reason turn against your body and start attacking your own cells. And there are 11 criteria for lupus, and you need 4 of them to say someone has lupus. But because there are 11, you have 10 different people with lupus, they can have all different signs and symptoms. So 10 people with lupus can look completely different. Some could have this classic butterfly rash, which is kind of right on the cheeks. Some of them never have a rash. They can have arthritis. Some never have arthritis. It can affect your kidneys, which is a real common problem with lupus. You can have anemia or low white cell counts or low platelets in your blood. It can affect almost any part of your body. Dermatomyositis is mostly inflammation in the muscles. You can get a rash, which on the face can look very much like a lupus rash, but then you can also get a rash right over your knuckles. And the biggest thing is your CPK, which measures muscle inflammation, is exceedingly elevated. So you have a ton of inflammation in your muscles, which makes you weak and achy. You feel a lot like kids with JIA, but instead of having the pain and swelling in the joints themselves, it's in the muscles. And again, with all these disorders, I'm going to talk a lot about stretching and moving, but it's really important that you stretch out because that minimizes the contractions which can cause disability later on. And again, scleroderma we see a lot. Systemic sclerosis is where it affects the whole body and it can affect your kidneys and your heart. there are a lot of what we call localized scleroderma. Scleroderma is basically thickening of the skin. It's an autoimmune disorder like all these others, but instead of affecting the joints or the muscles, it affects the skin. So the skin gets kind of like hard and waxy. Sometimes it starts off as red or white, and it feels very thick. And you can get lines of it, which we call linear scleroderma. You can get patches of it, which we call morphia. And sometimes, especially with the linear scleroderma, if it crosses the joint line, it can limit your ability to move your joint. So it's like arthritis in that you can't move the joint so well, but it's due to the thickening of the skin above the joint rather than the inflammation in the joint itself. So a lot of the treatments we use for these rheumatologic disorders are the same, regardless of what the diagnosis is. I'm going to talk first about some of the medications we use. And some of these your child may be on and you may know about. Some of them you may not have heard about. Very often we start with what we call non-steroidal anti-inflammatory medications, NSAIDs. And they're all relative to Motrin, Advil, ibuprofen, aspirin, and they decrease inflammation and pain somewhat. Some of them, there's traditional NSAIDs like ibuprofen can cause a lot of stomach upset, so they came out with these COX-2 inhibitors, which are like the traditional ones, but they don't affect your stomach as much, they don't cause as much GI upset, and they don't affect your platelets as much either. A lot of the traditional ones make your platelets less effective, so sometimes children get a lot of bruising. You know, they hit themselves a little bit and they have this massive black and blue mark. Usually it's more of a cosmetic problem. It's not necessarily dangerous, but a lot of kids don't like that they have bruises. So that may be a reason to put them on either Celebrex or meloxicam. Celebrex and meloxicam are also easier on your stomach. All these medications can affect your kidneys as well, and that's why pretty much any child on any of these medications we use, we have to get frequent lab work. And sometimes it's every month when you're first starting, going to every 3 months or so. But because all medications have at least potential side effects, even if very few of the kids actually get the side effects, the only way you know is by checking the labs. So that's one of the biggest problems for a lot of these children is they hate to get their labs done frequently, but that's the only way we know if they're having side effects from medication, so we need to do that. Oh, as a side, does everyone hear about Emla-Cream? Emla-Cream is a great thing. All right, for those of you who don't know about Emla-Cream, I'm amazed how many people don't use it. It's a topical anesthetic. It's this white poopy cream that you put on your arm at least an hour before the blood's drawn, and you put it on when you're home. You put some saran wrap on it. You go to the lab. As they're about to draw the blood, they wipe it off, and the child will not feel the needle. They'll feel the rubber band, and they'll still have whatever anxiety they had before, but after they do it a few times and they realize it doesn't hurt, the anxiety level starts to go down. It's prescription. You have to get a prescription from your doctor, but it's great stuff. The little kids call it magic medicine. Put a blob on, put saran wrap on, and ignore it until you get to the lab, and it really numbs up the area pretty well. So if you don't know about Emla, if you haven't used Emla, ask your doctor to give a prescription for that cream that numbs the skin up. They'll know exactly what you're talking about. EMLA.
Same as lidocaine?
It's basically lidocaine, yeah, it's a type of lidocaine. But yeah, EMLA, Emla cream, it's great stuff. And again, a lot of children, it's more anxiety or the idea of getting blood work, and it doesn't do anything for that. But it really makes it that if you don't look, you won't know. I have a daughter who's actually the most needle-phobic person in the world, and she's 12. And whenever I take her to the lab, I have to put the Emla cream on. We bring her iPod. She's listening to the music. We put a blindfold on. She puts her arm out. She's singing to the music, and she's like, "Don't tell me when you're doing it." And we turn her head to make sure they do it. She never knows. But I mean, it's a real process. But that's the other thing. If it's the idea of it, bring the iPod, bring a blindfold, just come to put their arm out, zone out, and they won't feel the needle. Been there, done that. All right, steroids. A lot of times children need steroids and they always hate it. Steroids can be taken by mouth. You know, kids with lupus take a lot of steroids, dermatomyositis take a lot of steroids, some systemic onset JA, even polyarticular, you know, sometimes need steroids. They hate it for different reasons than I hate it, and probably than parents hate it. The kids hate it because it makes them gain weight. If they're on it for a week or two, definitely not. But if you're on it for months and months, it makes them exceedingly hungry. They will eat everything in sight. And they get kind of the puffy cheeks, and it's obvious if you see someone who's been on steroids for a long period of time. And, you know, kids really get upset by that. Parents sometimes don't like it because it can make the kids bounce off the walls a little bit. Some kids get very hyperactive. You should always give the steroids in the morning. Don't give it at night. They will not go to sleep. Steroids can also be given as injections, which work really well for arthritis, but again, most of the kids don't like it. Sometimes if you need multiple injections, it's worthwhile to basically put the child to sleep, you know, give them an IV and sedate them, conscious sedation, and do multiple joints. But I found when it's only one joint, sometimes the IV is more of an issue than the injection itself, and you just kind of do it with the animal cream and everything else, and you numb it up and you talk to them. But still, it's an injection, the joint, and most kids do not like that. But I have to tell you, I don't know if your doctors use those faces for the pain scale, 0 through 10. I always ask the kids after I do a joint injection to rate it. And almost always they say like 4 or 5. No one ever says 8, 9, or 10. The anxiety may be a 12. And then I always write in the chart, and I remind them each time they come, in case they have to do it again. You know, I said, how's the data? It's okay, but you don't inject it, do you? I'm like, no, I don't. But remember, last time you said it was a 4 out of 10, right? And you said that he was hurting 6 out of 10. So the injection was less than some of the pain, but it helps bring the level of anxiety down when you remind them that, you know what, it wasn't so bad, and most of the time, we can get by with a 4 or 5. The other thing with systemic steroids, when you take them by mouth, it can, over time, give you all kinds of side effects, whether it's osteoporosis, it suppresses your adrenal glands, and, you know, there are a lot of potential side effects, so you always have to weigh pros and cons. Now, steroids are the only medications that work really quickly. Most of these medications take weeks to months to kick in. Steroids work fast. So if someone is miserable, they're having a flare, they really need something to start working quickly, that's the time to use steroids. Sometimes we use steroids to bridge the gap. Like, I'm going to start a new medication, it's going to take 2 to 3 months to really kick in. Let's give you some steroids, weaning it down over the next month, just so you don't have to feel so lousy while you're waiting for these other medications to kick in. But, you know, they're strong, they work really well, but they have lots of side effects. So, weigh the pros and cons. Then we have the whole group of medications that we tend to call DMARDs. Don't ask me who came up with that. Disease-modifying anti-rheumatic drugs. And the most common is methotrexate. We use that a lot for juvenile arthritis, for dermatomyositis, for lupus, for scleroderma, for a lot of these medications. Methotrexate works well in a lot of people. It can be given as pills. It can be given as a weekly injection. It's only once a week. And the injections do work better than the pills. For people who are not too needle phobic, you know, we definitely push the injections. It's only once a week. We use an insulin syringe with a really tiny needle. It just goes slightly under the skin. Again, anxiety can be a big deal, but most kids don't say it hurts a whole lot. The biggest problem with methotrexate is that 20-25% of kids who take methotrexate start getting really nauseous with it. And it gets to the point where, like, the injection is yellow, the medication, if you do the injectable, is yellow. They'll see that color yellow and they'll start gagging. Or the pills, you know, they'll look at the pills and they'll throw up or they'll start gagging. And they're not doing it. That some parents say, she gets herself so worked up, as soon as I start throwing up the needle, she throws up. But we don't see that with any of the other medications. The injections, any of the medications specific to methotrexate, it does something to the nausea center of the brain that not the first few times, but after a while, as soon as the kids hear the word, that nausea center kicks in and they get sick. And sometimes it's something we can work with. We give anti-nausea medications, help sometimes. A lot of the medications that they give with chemotherapy to prevent nausea sometimes work with the methotrexate, but sometimes they don't. And that's the most common reason for having to stop the methotrexate, is that the kids just can't tolerate it because of that nausea. The second most common reason to stop it is in teenagers. If they're going to drink any alcohol, if you're concerned that they might have any alcohol, you cannot mix alcohol and methotrexate. It will destroy your liver. So if there's any concern that someone may be drinking, it's like, please just tell me and we'll get you on a different medication. We don't want to mix them. Same thing, girl does not want to become pregnant on methotrexate. It can do really nasty things to the unborn fetus. If a girl wants to be pregnant, they should really stop the methotrexate a good 6 months before they're pregnant. Taking methotrexate as a child will not affect their pregnancy down the road. So 6 months after you stop taking the methotrexate, you don't have to worry about it anymore. It doesn't do anything to your eggs, it doesn't do anything to your sperm, it just does something to the fetus that's developing inside you. So once you stop it, wait 6 months, you're okay, but you don't want to take it while you're pregnant. Sulfasalazine or asulfidine, we don't use it that much anymore because there's so many more effective medications, but it's still very good for those ERAs, spondyloarthropathies. It tends to help a lot with them. Or sometimes when someone has just like 1 or 2 problem joints and you really don't want to go to methotrexate yet, it's kind of like a middle-of-the-road medication. Not too many side effects, unless you're allergic to sulfur, that's a really bad thing. But we use that sometimes. Plaquenil or hydroxychloroquine, great medication for lupus, dermatomyositis. We don't use it so much for arthritis anymore, but there have been tons of studies of lupus that show that it really helps prevent flares. So if we're able to get someone on all their other lupus medications and keep them on the hydroxychloroquine, there's a really good chance that they don't flare again, whereas when you stop it, the risk of a flare shoots way up. And because it has so few side effects, it's one of the medications that you can take during pregnancy. You can take it, lifelong. A lot of people say just call it, vitamin H and just take it all the time. A lot of pediatric and adult rheumatologists think that someone with lupus should take that forever because more and more has been coming out at how good it is at preventing flares. Celsep, another medication we use a lot for lupus, especially if they have kidney problems. Sometimes it gets rid of the need for stronger medications like Cytoxan, which is, chemotherapy for lupus. So, again, I'm not going over all the medications we use because there are so many, and I'm glad to answer questions at the end if you have any, but these are some of the more common ones, at least in the DMARDs. So what's new in rheumatology? All those DMARDs, all the medications we used to use, we basically stole from other subspecialists. For example, we used to use gold a lot, and we stole that from the pulmonologists who use gold to treat TB. Plaquenil, which I just talked about, hydroxychloroquine, is actually an anti-malarial medication. They used to use it to treat malaria. The sulfasalazine or zolpidem for spondyloarthropathies, they use that for Crohn's disease, ulcerative colitis. We kind of stole that from the gastroenterologist. Methotrexate, Cytoxan, chemotherapy. Because for years and years and years, no one even thought of looking for medications specifically for rheumatologic disorders. It just wasn't even on the radar. And then all of a sudden, the biologics came along. And these are exciting because this is the first time these drug companies looked for medications specifically for arthritis. And then that in and of itself was a major breakthrough. Because we went 50 years with no medication, and then all of a sudden, in the past 10, we have all these biologics being approved. And like I said, they totally changed the face of arthritis from when I was a fellow to now. Totally different ballgame. There are tons of different biologics, some still being tested, many of them on the market. The first ones to come out were what we call the TNF inhibitors. TNF stands for tumor necrosis factor. Tumor necrosis factor is a very inflammatory protein that they find in high levels in the joints of people with arthritis. And the first one on the market was Enbrel. Enbrel is a receptor to TNF. So it basically goes through the body, binding up all that extra tumor necrosis factor and taking it out of circulation. That worked so well. Then they came out with something called Remicade. Enbrel is an injection that you give to yourself either once a week or twice a week. Remicade is an IV infusion. So you have to go someplace or have a home infusion company come, you put in an IV, you get the Remicade usually once a month or so, and that's an antibody against TNF. Then Humira came out, which is also an antibody against TNF, but that again is an injection. The Humira is nice, and that's an injection, you can give it home every other week. The biggest problem with that is it really burns. Some kids tolerate it, say, it's not so bad. Some kids say it's like injecting acid into my leg. Other kids say it's like injecting broken glass. It's a great, effective medication for those who can tolerate it. But the Enbrel burns a little bit. Methotrexate doesn't burn at all. Humira really, really burns. So some kids will not take it for that reason. But if they can, it works. Also, if you have the eye inflammation, some kids with severe inflammation in the eyes that don't respond to other medications need either Remicade or Humira to control the eye disease. So they both work really well for that. Again, if it doesn't burn, Humira can do it at home. It's easier, but a lot choose the Remicade just because they'd rather have the IV than to get those injections. The IL-1 inhibitors are much newer. IL-1 is also what we call a very inflammatory cytokine. Cytokines are like messengers of the immune system. So this IL-1 and IL-6 also turn on the whole immune system and say, get revved up, let's react, let's cause inflammation. So by turning them off, you really help decrease the inflammation in all these rheumatologic disorders. Children with systemic onset JIA tend to do really well with the IL-1 and IL-6 inhibitors, where polyarticular JIA tends to do better with the TNF inhibitors. And again, all these diseases, we call it JIA just because we see inflammation in joints. But they're probably totally different causes, totally different mechanisms, so we lump them all into one big barrel, but each type probably will respond better to a certain medication because they're really different illnesses. We just kind of see the last step where the joints get inflamed. And that's why another reason it's frustrating, because sometimes you may try 3 of these before you get to the one that actually works, because we don't know exactly what's causing your child's specific type of illness. And, sometimes you're really lucky and you get on the first try. A lot of times you don't. There's another one, it's a co-stimulation blocker. Basically, it interferes with the way the B cells and the T cells talk to each other to get the immune system going. And that's called Orencia. That's also an IV infusion once a month. A lot of people who don't respond well to the others do very well with Orencia. And then the B cell inhibitors, which the Rituxan, although it's approved for arthritis, the B cell inhibitors we usually use more for lupus. The Rituxan we use a lot, and the Benlysta, which is the new one on the market, has not been approved for children yet, but it is approved for adults, and they will be starting trials in children. So again, just the fact that they're doing trials, we're having all these new choices, it's encouraging, not encouraging enough that, it's getting rid of the illness, but it's a start. We're going in the right direction for the first time in, over half a century. The biggest problem with the biologics are there are no biologics that we know of yet that you can take by mouth. They all get degraded in the stomach, so they all have to be given either as an injection or as an IV infusion. And again, children don't like that. People ask all the time about vitamins, diets, supplements, and unfortunately, everywhere you look, there's this new cure for arthritis. And everyone you see on the street, when you tell them your child has arthritis, they'll ask you, did you try this vitamin, or did you try eliminating nightshade vegetables, or did you try eliminating gluten, or giving mega doses of vitamin C, or fish oils, or everything else? Most of the time, unfortunately, there's actually no basis that this actually helps. The one exception are the omega-3 fatty acids. They have been shown to decrease inflammation in adults with arthritis. The problem with all these supplements and vitamins is that no one ever tests to see if there are any long-term side effects of giving high doses. So yes, some of them, like the omega-3 fatty acids, may actually work well, and it has been shown to work, but we have no idea if giving large doses of omega-3 fatty acids to developing children have any effect on them as they grow old. Does it affect the brain? Does it affect the nerves? Does it affect anything? So I always say that, multivitamin is a good thing. Definitely you want enough calcium and vitamin D. And, if you get your kids to eat a few pieces of fish a week, that would be great. If not, reasonably low doses of the omega-3 fatty acids may be helpful. But I'm very concerned about people who, come in with these bottles of vitamins and supplements that may help, may not, but may cause harm and may not. And they've never been tested. They're never going to be tested because FDA doesn't require them because they're supplements, they're not medications. So I just encourage you to be careful of these things that no one really knows how they affect children. I want to spend time talking about exercising and stretching because for all rheumatologic disorders, it's so important that kids stretch. I mean, a lot of times we recommend physical therapy, occupational therapy, but I always tell the families, if you go to physical therapy twice a week and you don't do your home exercise program, you are wasting your time and money. Even if you can get them to do 10 minutes a day, it doesn't have to be hours, but stretching, if they have an exercise program from physical or occupational therapy, that's great. If not, just generic stretching is so important. And it's also really important for these kids to move, to do some type of aerobic activity at whatever level they can do it. Exercise, it improves the flexibility, it improves the muscle strength, endurance, and it makes kids feel better. It really does. Kids who exercise, whether it's walking or riding a bike or playing on a sports team or whatever it is, they generally complain less of pain than kids who don't. And there have been a lot of studies that have shown that. They do controlled studies and they give one group of adults or children these exercise programs. And whether it's the endorphins that are flowing more, whether it clears the head, I don't know if sometimes after you go for a walk or a run, you do something, you just feel like you face the world better. Well, the same thing works with kids. Kids are meant to run around, all right? They do that. If they're limited by their disorder, they may not be able to do what some of the other kids are doing, but they can definitely do something. Conditioning programs are key. They even found that, not overdoing it, but just getting into an exercise program actually decreases the inflammation in the joints too. And again, I'm not sure if it's because you get the adrenaline going and that's an anti-inflammatory or no one really knows exactly why, but not only does it decrease their perception of pain, but it actually makes their joints look a little bit better. So why don't children exercise? Well, sometimes they're afraid because they remember that last time they hurt. The gym teacher made them run a mile when they shouldn't have run a mile and they couldn't walk for the next 2 days. Sometimes it's because they may not do things so well. I'm always the last person picked on the kickball team or whatever because I can't run quickly because I limp, or I can't hit the ball in volleyball because my wrist hurts, so I try to get out of the way and the team yells at me. And sometimes it's because the parents are afraid. I have a lot of kids who want to go out for sports teams, want to go out and do things, and the parents are just afraid that it's either they're going to settle their arthritis and be in more pain, or, well, I don't want the other kids to laugh at them, or I don't want her to try. There's no way she's going to make that team. I don't want her to have to deal with that. It's bad enough she has arthritis. I don't want her to feel the letdown of not being able to do something. So we have to come up with some kind of reasonable compromise. When someone has a lot of inflammation in the joints or muscles, they're having a flare, really just stretching, walking, very low-key exercise. You can always do that. Riding a bike very slowly, just moving. If they're not having a flare and they're doing reasonably well, almost any non-contact sports is fine. You just have to explain to the kids that your body is really good at telling you if you're overdoing it. If you're running and your knee starts hurting, you got to slow down, walk for a while. It doesn't mean you have to quit the team. It doesn't mean you can't run the next day. But just slow down for a while. Otherwise, you're really going to pay the price the next day. And if your kids kind of learn to listen to their bodies, they can actually do well. I have patients with really significant arthritis on almost every sports team you can think of. You know, as long as their coach is understanding that, you know what, there may be some days they're not going to be able to play or they're going to have to come out early. And the kids know they have to stretch out really well before and really well after activity, especially after. The teams are very good about stretching out before, but all the new research is showing that it's so much more important to stretch out after activity, whether you have arthritis or not. Because when your muscles are really hot and inflamed and tired after doing activity, if you don't stretch them out, they contract, and that's when you get really sore, and that's why you sore that night or the next morning. But if you take 10 minutes and stretch out after activity, you really minimize that. So that's really important. So if you have an understanding coach and you have a kid who's willing to say, all right, if it hurts, I'll try to slow down a little bit, there's really not much they can't do. I strongly discourage football. I strongly discourage high diving and gymnastics up to a point. You know, little kid gymnastics is fine, but I worry about the neck. So, you know, things that you can fall and really hurt your neck, and someone with arthritis at the neck, they're much more likely to have severe injury. But soccer is great. You know, people on swim teams are great. Girls lacrosse is great. Boys lacrosse is like football with weapons. But I do have, it's crazy what they do each other. But I do have a lot of boys who, to my chagrin, play lacrosse. But, you know, again, it's always a balance. You want to keep them safe, but you want them to feel normal. And the kids who play sports, they feel good about themselves. They can do something. And, you know, especially if it's like the town league or something where it's not quite as competitive, or the, you know, just clubs or intramurals, you know, just the idea that they can get out with their friends and do things. And that's why I never, ever get someone out of gym. You know, I always do physical education as tolerated. Do what you can do. That way the gym teacher can't fail you or give you a bad grade if you don't do something. You know, if they're running a mile and you can't run the mile, you walk the mile, but don't sit there. And if you're having a good day and they're playing volleyball and you can play volleyball, or they're playing whatever and you can play. You really need to encourage activity as much as possible. It makes them feel better, it makes their joints better, it limits the disability that comes from stiffness and not using the joints and muscles, as long as they don't overdo it. And what usually happens is they overdo it once or twice, and then they learn not to overdo it again. And it doesn't do any permanent damage, it just makes them really sore the next day or two. So that's the other thing. They're not going to do something terrible, they're just going to be really visual if they overdo it. And they'll learn, and it takes a while. So again, I think I've killed this one. Stretch, stretch, more stretch. My patients always laugh at me because I tell them that 10 times every visit, stretch. And like I said, strengthening, conditioning, it all helps to the general sense of well-being. All right, so any chronic illness, the biggest problem I face, and probably one of the biggest problems you guys are going to face, is compliance. They don't want to take their medicine. It could be because when you take medicine, it means you're sick. You know, they want to be like their friends don't take medicine. If I don't take medicine, I'm okay. Sometimes it's because they're feeling well, which is a great thing. Our medicines work so well now that the ones that they're really willing to take when they feel crummy, once they're feeling better, they think they don't need it anymore. Why do I need to take it? I'm fine. And sometimes it's the side effects. You know, I was talking to one of the pediatric rheumatologists here, and she was talking to me about a patient she has with lupus who stopped taking her prednisone because it made her gain weight. And my friend said to her, well, which would you rather be, thin and on dialysis because your kidneys don't work, or gain weight with a prednisone? And the girl looked at her straight in the eye, a 16-year-old girl, and said, I'd rather be thin on dialysis. So, you know, especially in teenage girls, image is so important. And so many, well, not so many, steroids specifically, you know, it messes up your body image a little bit, it really does. Almost everyone on steroids gains some weight. Now, a lot of times you can control it. You know, by really watching what you eat, understanding that you've got to be hungry all the time and you can't eat every time you're hungry, having tons of low-cal snacks around, and exercising. Exercising really helps. But some kids, even if you do everything, they still gain some weight, or sometimes it makes them get acne, especially during the teenage years. So a lot of these medications, specifically steroids, people looking at them, all of a sudden they know something's wrong. Whereas if they look thin and then they're having a flare, they have to go to the hospital, well, maybe their friends won't notice. So it's really hard to overcome that. Luckily, most of the medications don't do that. It's mostly steroids. But again, I don't want to take a shot. It hurts. It's not fair. No one else has to take shots. And they get angry. They get angry that why is this happening to me? And you can't blame them. I mean, we all be angry. We all are angry. Kids say, I don't want to be sick. It's not fair. My friends don't have to go to the doctor. My friends don't need a lab test. Why do I have to do this? And, with any chronic illness, it's something that's really hard on you as parents to deal with, because on the one hand, you have to acknowledge that they're right. You're right, it's not fair, it sucks. Yeah, it's terrible that you have to do this. But on the other hand, you have to kind of tell them, but there is a bright side. You're feeling better. You can play sports now, you can do things now, or it's going to get better. Or, yes, but you have to take the medicine, but if you do that, look at all the things you can do. And again, emphasizing the cans instead of the cans is really, really helpful. Every year, they'll have a year, and every arthritis conference, whether it's our local state conference or the national conference, they always have a panel of young adults with rheumatologic disorders, and parents can ask them questions. If you haven't been to that, go to that. It's the best session for any conference. But what comes out again and again and again, parents always say, what did your parents do that helped you? What did your parents do that hurt you? And almost always what comes out is the things they say the parents did that was the best thing, they treated me like a normal child. They made me take out the trash the same way they made my brother take out the trash. They made me do chores around the house. They made me go to school even when I said I didn't feel well. Because they showed me I could do it. They made me ride my bike when we went on a family bike ride. Trying to treat the child as normally as possible. And again, within reason. There are days that the child can't do some things. But when they can, not to, tiptoe around them, but to try to treat them and make them think of themselves as normal. I'm a normal child, but I have arthritis. Or, I'm a normal person with lupus, as opposed to, I am arthritis, I am lupus, this is who I am, this is me, this is my life. As much as you can minimize it, and make it, yes, it's something you have to deal with, but you're just like your friends in all other regards, and you're just like the rest of his family, they say that's helpful. One kid, I remember one of the panels talked about, how they went on family bike rides, and the parents made them ride like 10 miles all the time. And she said, oh, my knees were killing me, and this and that. And she said now, looking back, she's so thankful because she thinks that really helped her, get into shape and not have as many problems as she would have. I think that's a lot. But, it worked for her. It depends on your family and what you do. But when you start looking at your child as a sick child, whether you mean to or not, you start treating them like a sick child, and they start thinking themselves like a sick child. And that's what we want to avoid. And that all starts with you. Because when you're thinking them as sick, it comes out. They look in your eyes. They see the tears, or they see the frustration, or they see when I can go out and play with my friends, but they kind of hesitate because they don't know if they really should or not. They are so perceptive. They pick up everything. And sometimes it's better to let them try and fail than not to let them try. Because again, if they go out and then they're sore the next day, they'll be sore the next day, but they did something. And sometimes, especially with the older kids, like they ask me if they can go to do something, and I tell them, well, you don't have to decide if it's worth it or not. Because if you overdo it, you're really going to pay the price the next day. But if it's worth it to I had one girl who said, she really wants to wear these high heels to the prom. And she's like, but I can't because my ankles swell up the next day. Every time I wear high heels, I can't walk the next day. But I'm doing this because I really want to go to the prom. I said, okay, so we'll take some extra Advil the next day. If we can feed up, you're not going to be able to walk for 2 days. But have a great prom and that's what you're going to remember, do it. So it's a fine balance because especially as parents, you really want what's best for your kid and you don't want them to hurt and you don't want them to have problems. And, you know, probably all of you, if you could say had this disease affect me instead of my child, probably all say, yes, please, you know. I'm a parent too, I understand that. But sometimes letting go a little bit is really helpful for them. And again, you know, when you talk to the older teenagers, young adults, that's kind of the message that they seem to bring, you know, when they talk on panels. And the thing that surprises me a lot, every panel, someone will say something like, you know, I hate arthritis, but if I had a choice of living my life without it, going back, I would do it because it's made me a better person. You know, it's made me more sympathetic to others, it's made me understand things, it's made me not worry about the little things. But every time someone gets up there and says that if I could trade and never have arthritis, I would trade. And that always blows my mind because you see how much suffering some of these kids go through, especially during flares. But to have an older person come back and say that, you know, it stunk, but it's really put me in a better place now, I think that's remarkable. And maybe it's not so remarkable, but I think it is. So, and then, you know, the last thing I want to say before I open it up to questions is that things like you're doing now are really, really helpful. It's so good for kids to meet other kids who have similar disorders. The conferences are great, and you'll see, especially older kids, they'll keep in touch with each other. They'll want to see each other at other conferences. They'll Facebook, they'll text, they'll email. The camps, I've had more good comments about camps, how camps change kids' lives. A lot of states or regions now have sleepaway camps for like 5 days or something like that. And to go to camp and be surrounded by people just like you, maybe everyone's a little stiff in the morning, everyone has to go to the nurse and take their medication, the nurse comes around and gives everyone their shots, but then they all go boating or fishing or play basketball and do whatever, and they feel so normal. And a lot of times for our New Jersey camp, we have them, it's sponsored by a group called the Artels, we have them write letters to the Artels, you know, say thank you after the camp. And, you know, they always write, you know, I've never felt so at home, I belong here, I never realized there were so many people like me, or I never realized how lucky I am. I only have to take, you know, 4 pills every day, but Johnny has to take 7 pills and take 2 shots. You know, just seeing other kids and being exposed to them, and yes, you have your issues, but so does everyone else here, and let's all have fun, and let's all do things, and you know what, we're all kids that have to take medicine, and maybe we move a little slowly in the morning, or maybe there are days we can't do things, but we're all in this together, and we're having fun together. It's great, and again, they keep in touch, and sometimes, you know, kids tell their friends, sometimes they don't tell their friends, but the friends don't really understand. They can be nice and sympathetic and try to understand, but they don't understand. And having friends who truly understand what you're going through when you have a bad day, having someone to call who can honestly say, been there, done that, is really helpful. So I highly encourage you guys to get involved in as many of these activities as you can and allow your children to meet other children with rheumatologic disorders, because over the years, it's really helpful for them. So what are the main issues that are the problems at this point? Well, the big one is we don't understand rheumatologic disorders. We don't know what causes it, and until we know what causes it, we can't really cure it. You know, we can control the symptoms. All these medications control inflammation, control the symptoms, but nothing actually gets at the cause because we don't know the cause. So we need research. I know all of you guys know about CARA, Childhood Arthritis and Rheumatology Research Alliance. That's the big research group for all pediatric rheumatologists in the United States and Canada. We do lots of research. We're getting a registry going now. I don't know if your rheumatologists have asked you to join the registry. We're trying to get all kids with any rheumatologic disorder in the United States and Canada in this long-term registry so we can follow over time and see which medications work better, you know, what the natural history is, what, you know, things actually make a difference. So ask your rheumatologist if they're involved in the CARA registry, and you can always find out more about CARA, you know, in terms of research going on now. And the biggest thing out there is, you know, we don't just want medications to treat the symptoms, we really want to cure it. That's it. anyone has any questions.
You're talking about early medication. My children were fortunate enough, over 2.5 years ago, they hooked up with a nutritional product that's realistically changed their lives. Medication-free, pain-free, going on will be 3 years in November. Has omega-3 fatty acids in it. And the only reason we were introduced to that product is at the time, my 9-year-old daughter at the time had to come off medication because her kidneys were failing due to the medication. So rheumatologists had to take her off the medication. And by that, opened my wife's eyes to try something different outside of the box, what everyone was telling us. And it's been the greatest thing for us. And my question is that, you know what, I think arthritis and many diseases, correct me if I'm wrong, is due from your immune system failing. It's not able to fight it off naturally. This particular nutritional product helps you build your immune system so you're able to fight off not only my son has psoriasis, that's gone. More pain, he had, my daughter had bladder influx, migraine, gone. I feel that it's building your immune system to fight off this disease naturally. And you said you're not testing on it, I understand, and 50 years down the road, they might find out there was a terrible side effect. Enroll is very new. 50 years from now, you can find the same results. I'm saying no one knows what's going to happen 50 years from now.
No, you're correct. And there are many things out there that some people swear by. The problem is when they do studies where they take 50 children and give them 25, some supplement and 25 they don't. What tends to happen is some in each group get better and some in each group get worse. And there hasn't really been a statistical significantly different rate. And probably part of that is due to the nature of the illness, like I said, a roller coaster. People go into remission for years. It starts for no reason. Sometimes it goes into remission for no reason. Sometimes it comes back a year or two later. Sometimes it never comes back. And we don't really understand it. I'm not doubting that there are some products out there that may be helpful. I'm just very concerned that not only haven't been tested, but none of them probably will be tested long-term looking for side effects because there's no reason to. And like I said, I've seen people who've stopped their medications and taken supplements and did really well for a period of time, but then they come back with all this damage that can't be undone. And not that that will happen to any individual person, but I've seen a lot of people kind of take a year or two off and do the holistic route and then come back and they're like, well, I can't kind of go back and undo the damage. Let's get you on these medications that could prevent more damage. And you're right, a lot of our medications are new and we don't know the long term, but at least they're looking at it and we will know. And the medications that have been around longer, we do know. So I'm not saying there aren't things out there that might be helpful. I'm just saying I don't have enough information. And, actually, with most autoimmune diseases, it's actually a hyperimmune state. Your immune system, it's not that it's too weak. It's that it's confused and turned on itself. You're making too much of an immune response, not enough. So it's not that your immune system is weak and failing and not working well. It's that it's almost working too well and that something triggered it to start attacking your own body instead of just attacking infections.
I had a question on how this might affect the height, because my daughter was on one set of medications for a year, and it really seemed like she stopped growing and the other kids were growing, just 10. And then we just changed the medicines, and I think she's starting to grow again. So is that possible from the medicines or the disease, or is that like normal?
Well, steroids definitely can affect your growth. I don't know if she's been taking steroids. Steroids can definitely affect your growth. And a lot of times once you get kids off steroids, they'll do some makeup growth. Inflammation in your body can affect growth. So if she's not well controlled and there's a lot of inflammation, that will affect growth also. And a lot of times once you get the inflammation under control, they'll start growing again. Most of the medications that we use should not affect growth.
If she did stop growing for a year, now she's really doing better with arthritis and better on food medicine, but she's going to make up that loss get to a regular height, or we don't
Unknown. Sometimes, the younger they are, when they don't grow, the more likely it is they'll make it up.
She was 9 when she wasn't growing.
Yeah, it's impossible to say. There's a good chance she'll do some makeup growth, but whether she'll reach the height she would have, it's really impossible to say. And the other thing I want to say is that I'm a staunch believer that for all medications, you have a list of side effects that you can expect. But I really believe that almost anyone could have almost any side effect from almost any medication. So that even though it's not listed as one of the top 10, 20, 50 side effects, if your child's having a particular reaction and you think it's from the medication, even though it's not listed, it might be, and it's worth changing because we have enough medications available now. Because you see that sometimes people have these side effects and you stop the medication and the side effect goes away and you restart and it's there again. I'm like, well, that's not supposed to be one of the side effects of the medication. Well, it is. for this one person, it is.
Question in terms of the medical field. You described at the beginning, I'm sure a lot of people have been through this, we had the same thing, the frustration of getting a diagnosis. When we started with your orthopedist who said exactly what you said, he walks just fine. There's a problem, and actually the inner circle, when I called that orthopedist back and said, here's eventually where we wound up, and I want you to know, because I don't want somebody else to have to go through this, I want you to ask the question. What is happening in the medical field between people who have a very good understanding of rheumatology and other practices? Because what we sort of heard is that other doctors just really don't understand rheumatology.
It's true. It's definitely a problem. And the biggest problem is there aren't enough pediatric rheumatologists in the world. There aren't enough of us to go out and educate everyone else. And there are medical schools that don't have pediatric rheumatologists there. So the people at the medical schools, they never see a pediatric rheumatology patient. There are states with no pediatric rheumatologist in the entire state. I come from New Jersey. We're pretty lucky. We have a bunch of pediatric rheumatologists. I'm very good friends with an orthopedist who organizes something for school nurses every year, and I always give a talk about juvenile arthritis, and sometimes they have things for primary care physicians that I'll talk at. But honestly, it's extremely limited. And, I wish there were more of us and there was more time. Again, it takes time to go out and talk, and we're all so bogged down because we have so many patients. But it's a real problem, and I don't have an answer for you.
I'll look him up with Thursday, right? He's Thursday for his 1 year now. They take it orally, and he started getting hemoglobin and mouth sores. Is that the same side effect if you were getting the injection form?
The question, I don't know if you guys heard, but someone taking oral methotrexate who gets mouth sores, can get the same thing from the injections, and the answer is yes. Sometimes doubling up on the folic acid helps a lot. Take like this. Yeah. Right. Yeah, that doesn't make a whole lot of difference. But for the nausea, sometimes when you change, whether you change from the pills to the shot or the shot to the pills, it doesn't matter. Sometimes just when you change helps that. I think we have about 2 more minutes. I'll try to get a couple more questions in.
This is a little bit of an odd thing. As a real wife, you guys support extended building. She also has 7 classes. And we've seen the child at primary surgery center. What kind of things can we do to kind of keep him safe? Really can't help crashing, banging, growing his body, his knees, more. What advice as a pediatric oncologist do you kind of be very active soccer, baseball, but non-soccer?
Yeah, you know what? Sometimes with kids, you can't stop them from doing what they do, and right, and you know what? I don't know if there's any this is swim.
He swims, we have him PT, we have him.
Right, sometimes schools are really good for children like that, they're less likely to hurt themselves when they crash, and it's like that buoyancy kind of helps a lot. And I have to think about that one.
Okay.
Sorry. Okay.
Also, I want to make sure I say
Is there any difference between taking the regular and then versus compound? Is like chalk from better? Or is
You mean compounded to a liquid?
yes.
No, it really doesn't make, if it's a compounding pharmacy and they're doing it well, it should be fine. I mean, again, the shots still work better, because when you take it by mouth, whether you take the injectable form by mouth or the pills, some weeks you absorb 85%, some weeks 90, some weeks 70. It's a little bit erratic sometimes, whereas the injections, you absorb 100% every time. And also when you take it by mouth, it goes to the liver first, where it changes it and takes it out of circulation, and the injection doesn't happen. If someone's doing well on the oral form, that's great, keep with it, but if they're not, there's a good chance they would do better if they took the injections. All right, last question.
You mentioned at the end that the goal is to find a cure. How realistic is it, given that essentially you have to suppress the immune system? I mean, are people actually working towards it? Or is this,
Well, right now we're looking towards figuring out what causes it, because there's a lot of genetic testing and mapping and all these things. If we can find out that, this is caused by a certain mutation or a certain predisposition, and they may have a certain virus that causes something, if we can figure out what causes it, it would be so much easier to find a cure. Right now, we just see the effects, we see the inflammation. And again, when I was doing my fellowship, the effect was inflammation. We didn't know about all the cytokines, TNF, IL-1, IL-6, and now we've taken another level. It's not just the inflammation, but these are the cytokines that are causing the inflammation. So instead of just turning off everything, let's go specifically at these specific cytokines and turn them off. And you seem to have less side effects that way, because like prednisone just turns everything off. The biologics turn off one specific side effect. Now we can take that back another step. Why do they have these high levels of cytokines? And if we can keep going back, eventually we'll get to what causes it and have a cure. But I think it's really hard to talk about a cure until you know what the underlying problem is. And that's the biggest thing. We don't know. Child's fine one day, and all of a sudden, out of nowhere, they have this rheumatologic disorder. What happened? And then sometimes it goes into remission. Your body it cures itself. Why is someone who's had this for years and years all of a sudden goes into remission? And is it a permanent remission or a remission for weeks, months, years, decades? Once we understand that, it'll be a lot easier to get through it. All right, thank you very much.
She ready, call?